and I will be talking about a hallux valgus case. Usually in the examination, it will come as a short case. So if you are preparing for your MRCS or FRCS exam, then this case is important. And it's a good case to score. So you can get good marks in this one, which can compensate if you have made any mistake in any other case. But it will come as a short case. It will not come as a long case. So in a short case, what happens in the exams is that the examiner will be with you and the patient is standing there or sitting over there, and then you have to examine and take history in front of the examiner. So the question answers will go on for 5 to 10 minutes and that's it. So you have to be really sleek and you get in hallux valgus case so that you can score more points over there. So first of all, what is a hallux valgus? It's not bunion. There is a difference between hallux valgus and a bunion. Bunion is just a swelling over the medial side of the joint, MTP joint, which can be because of anything, bursa, dermatitis, keratosis. But hallux valgus is the deviation of the great toe. So the deviation of the great toe is also that the great toe goes laterally and the metatarsal, the first metatarsal goes medially, leading to the subluxation of the MTP joint. That's hallux valgus. So if I can explain the anatomy to you and if I can explain what happens, why the deformity occurs, I think my job is done here. So, but for that, let's go through the anatomy. So what happens is that you have first MTP joint is a very flexible joint and it has got a lot of movement, but it can become unstable also. So there are soft tissues which are holding it in its place. So they are trying to balance the MTP joint. So on the medial side, you have got abductor hallucis, which is trying to push the phalanx medially and metatarsal head laterally. And on the opposite side of the MTP joint is adductor hallucis. You've got two slips of adductor hallucis, which forms a conjoint tendon, and then that inserts on the proximal phalanx. So, and then along with that, you have got long tendons on the flexor side as well as on the extensor side. So how the deformity starts. But before we go into that, let's look into one more important feature of the base of the first metatarsal. So if you can see my cursor over here, so that is, you are looking at it from the plantar aspect, so from below. So you can see this is a separation, a bony separation for the two sesamoid bones, and this is called as cresta. And that keeps the two sesamoids separated from each other, but it also keeps it in its place because there is a ligament which is keeping the two sesamoids together, and the cresta is keeping the sesamoids in its place underneath the head of first metatarsal. So let's look into the deformity. What happens? So now if you look at this slide, now this is how a normal foot would look like. You have got on medial side, you have got abductor. On the lateral side, you have got adductor hallucis, and underneath you have got two sesamoids, flexors and extensor tendon. And this is cresta, which is keeping the two sesamoids together. Now, we don't know exactly what happens and why the deformity starts and which side gives in first. Whether it is, well, when I was a student, then they used to say that it is the cresta, that the cresta becomes flat, and then when the problem starts. But then there was another school of thought which was saying, no, it is the abductor hallucis, which becomes weak and is dysfunctional and moves plantarwards. So it comes here, and that's how the deformity starts. Or maybe there is a medial capsular attenuation, and which leads to the lateral capsular shrinkage, causing the deformity. So this is important. That will explain how the deformity happens and why you get the valgus and the pronation in a hallux valgus. So let's look at this slide. So now I'm trying to explain this thing in detail, that now this is your big toe, and now that's the metatarsal, which is first metatarsal and the proximal phalanx. So what is happening is, if you believe that there is attenuation of the medial side of the capsule and then there is a shrinkage, so it is causing this lateral shift of the phalanx. So after that, the sesamoid starts to move laterally. So the holding structure, that is the cresta, which was keeping the two sesamoids underneath the head, is gone. So now once the cresta is gone, your sesamoids will start moving laterally. And if on an X-ray, you can see the uncovering of sesamoids, that means now the cresta is gone and this deformity is going to be progressive. So if your patient asks you that what happens, can I leave it? Is it going to progress? Yes, because there is uncovering, so it is going to progress. But at what speed, we don't know. So, and then we are saying that the abductor has also become dysfunctional. So if abductor is not stopping the metatarsal head from going medially, the adductor is still active and is pulling the great toe laterally. And this is going to cause further deformity. Plus the long tendons, the axis of the long tendons is also going to shift, and that will aggravate the deformity and will cause pronation. So the pronation is also more or less, it's a combined process. It's not that one thing will lead to, everything goes in, but once the disease becomes progressive, the pronation will come. Now, why this thing happens? We don't know. Most of it, many times you will see that it is genetic. Females have 15:1 ratio. You can get it because of trauma also. But the other conditions that can lead to hallux valgus are inflammatory, neuromuscular, and connective tissue disorder. So you have to look into that also when you are thinking that is it because of this. The easy, usually you will see it is one side is more deformed and it is just the big toe. But if you start seeing the lesser toes also too deformed, then you have to consider that it may be an inflammatory arthropathy. And on the opposite side also, if the condition is similar, then you are dealing with inflammatory arthropathy rather than a idiopathic hallux valgus. Now, another important point is that why footwear is important. Most of the time, women like to wear high heels, and with the high heels, they have got a narrow toe box. So that keeping that foot in that position with the pointy heels, and in case if your shoe size is one size smaller, so that your foot looks good, that can aggravate your problem. But whether that causes it, we don't know. Now, when the patient comes to you, the patient will come to you with two problems, mainly pain and cosmetic. So pain is one thing that you should try to help the patient with. And for cosmetic reason, it will be a young girl coming to you asking that it doesn't look good, it is not going with the shoes or things. So she would like it to be modified. So then you have to be very careful with that. And many times that you will see that these patients will come to you in winter because they are finding it difficult to put their footwear on. And because the footwear hurts, and that's when they would like to seek medical attention. In summer, they are managing with their slippers, but in winter, they would like to go in their shoes, so that hurts. And if you look at this slide, that if anything goes wrong over here, it is going to create a problem. So now you have got 5 minutes, your examiner is standing next to you, so you have to examine the case. Now, I will not go into the detail because all my colleagues have discussed all the tests so far. So basically in 5 minutes, what you can do is that you start with the gait. You ask the patient to walk, you take his footwear in your hand and you examine the footwear. The footwear will give you the bumps and the wearing out of the sole, and that on the bunion side also, you will be able to appreciate the wear and tear of the footwear. You look at the skin, it's very important in a foot and ankle case that you have to look at both the sides, the dorsal as well as the plantar. When you are looking at the patient in the standing, you are looking at it on the dorsal side. You look at the patient from the front, side, back, and then you ask the patient to sit down. And when he's sitting, you take the foot in his hand and you look at the plantar side of the foot. When the patient is walking, you should also look at the hind foot. It is not just the forefoot that you are dealing here with. You have to rule out the problems of the hind foot, because the hind foot problems can lead to compensatory forefoot deformities. And the important thing is that for that, because we would like to correct hind foot before doing the forefoot. So now when patients, the dictum remains the same, you feel, you look for it, you feel, and then you move. Now the important question is that when the patient says they have come with the pain, now where is the pain? Which joint is causing the pain? Is it the great toe, MTP joint, or the TMT joint that is causing the pain? And is it the lesser toes which are causing the pain? You can have transverse metatarsalgia because your first tray has become dysfunctional. Now your weight bearing is mainly on the lesser toes. So you can get pain on the lesser toes. You can have overriding of the toes. You can have callosities underneath the lesser toe. But if that is because of the compensatory failure, because of the failure of the first tray, and then you are getting this compensatory transverse metatarsalgia, that could be the reason that the patient has come to you for the pain. But yes, the problem is with the hallux valgus. So if you correct that, that problem should also be sorted out. So then when the other important thing is that when you have got few minutes with you, you should practice how you are going to hold the foot when the examiner is standing next to you. So there are two ways. I have demonstrated that you can use it either this way, or you can use it either that way. And then you are trying to palpate, you are trying to see the tenderness of the joints, and then you are trying to move the joint. So the pronation, the deformity, is it correctable? If it is correctable, yes, it is not too bad. And then if the movement of the great toe is painful, if it is painful, that means it could be because of arthrosis which is developing. So that will change your surgery. So that is why you are interested if you are dealing with an arthritic or an inflammatory arthropathy, and plus the mobility of the MTP joint. At the same time, you have to look at the hindfoot and the neurovascular status, but that becomes, that will be a very big examination. And if you mention that also, that the hindfoot, that you would be looking into hindfoot and the neurovascular status, the examiners are going to take it for with you. And now the examination is of hallux valgus is never complete until unless you have examined the TMT joint. Because if you have got a laxity, and that's the reason that you are getting a compensatory hallux valgus of the TMT joint, then your surgery of dealing with the MTP joint is going to fail. So this last test is very important. And you have to do this test few times before you can get to grips to it. And it's a subjective test. It's not very easy to do that. You stabilize the hindfoot and then you try to move the first metatarsal up and down to assess the laxity of the TMT joint. After doing few, you will be able to appreciate, but it is not easy. I appreciate that. And now after the examination part is complete, the next step would be to look at the x-rays. So you are asking for weight bearing x-rays, like we have been discussing in foot and ankle. Weight bearing x-rays are important. So in a hallux valgus case, you are looking mainly for three things: deformity, congruency, and arthrosis. So what I mean by deformity, because deformity is hallux valgus. So how bad is the deformity? You would like to classify the deformity into stages, and whether the joint is congruent or not, and if you have got some arthritis in it. So let's talk about the deformity first. Now, the angles that we look at it, you can calculate the angles on a standing weight-bearing AP view. The first angle that we usually calculate is a hallux valgus angle. It's basically the line bisecting the first metatarsal and the phalanx, and it is usually less than 15 degrees, which is considered as normal. The next angle, important angle, is the intermetatarsal angle, which is less than 9 degrees, and it is the angle between the long axis of the first and the second metatarsal. And the third angle is DMAA, which is distal metatarsal articular angle. It is not that important in the adults, but when you are dealing with a juvenile, you would definitely like to correct that also. And now coming to what is the meaning of congruency and the incongruency of the joint. Basically, if you look at this picture, you can see the articular surface. If you look at this x-ray, the articular surface is from here to here of the phalanx. And so that is from X to Y. And similarly, the articular cartilage of the first metatarsal is from X dash to Y dash. So they are corresponding to each other. So this joint is congruent. Now look at this picture or this one. There is uncovering of the head of the medial side of the first metatarsal. So it has moved downwards. The joint is sublux. So this joint is not congruent. So if you are planning to do something for this case, surgically, you have to bring this joint from incongruent position to a congruent position. And now arthrosis is, it's like an arthritis, but now after we have calculated the angles, the next stage is to decide whether the deformity is mild, moderate, or severe. So that is the classification for hallux valgus. So it's basically decided by the hallux valgus angle and the intermetatarsal angle. So anything which is between, which is less than 15 or less than 9 degree for intermetatarsal is considered to be normal. And mild is hallux valgus angle of less than 20, and intermetatarsal, some people consider 9 to 11, some consider 9 to 13. So, but there is variation as long as you understand what they are talking about. And then if the deformity is severe, that means your hallux valgus angle is more than 40 and your intermetatarsal is more than 20. But at the same time, you are looking at the congruency of the MTP joint. When you are talking about a severe deformity, your joint is not congruent. So a joint with that much of deformity, with severity of that much of hallux valgus, there will be pronation and the DM, and there will be an incongruent joint. So you have to correct both of them. Now, coming on to the treatment part. So for all examination purposes, it has to start with conservative management first. Surgery is done for the failure of conservative management. And the treatment goals have changed over the time. When they started operating on hallux valgus, initially they were happy just doing the medial soft tissue release as well as lateral side release with resection of the exostosis, but then the results were poor. So in 1934, Lapidus mentioned about intermetatarsal angles and the deviation of sesamoids, and these corrections should also be done. And over the years, now we have started thinking is taking it as a, we have to look at the whole package. So how I look at it, this whole package. So for me, patient complaints and occupation are very important. What is his main complaint? Whether the radiological and the clinical signs match. The age and the lifestyle of the patient will also decide what surgery you are going to offer. The neurovascular status, general health. Plus, what I would like to add is that you should also ask the expectation of the patient. If you are doing it for the cosmetic reasons, then your results are going to be poor. Trust me. Now, there are for hallux valgus, there are more than 100 surgeries, I think, described in literature. But that means that there is not one good surgery, and that for a hip arthritis, you do a total hip replacement, and everybody is happy with that. So yes, for examination or for satisfaction point of view, you've got a great surgery there. But if you have got so many surgeries, that means something is not right. So either we are missing something or maybe we are not doing it right. So just I will tell you that where you can do the osteotomies or where you can do the surgery. So this is just the bony procedure we are talking about. And so if you start with the phalanx, so you can do a medial wedge resection, that's known as Aiken. You can do a fusion of MTP joint, or you can do a Lapidus, which is TMT joint, and then you get a whole metatarsal. So if you do it distally, it is distal. Then you can distal osteotomies, and if you do it on the proximal side, it is proximal, and in between is the shaft osteotomy. So that's how basically you have divided all the surgeries on the first ray. Now, how I decide what you have to say in the exam in case if you get case, if you have calculated the angles, or the examiner will give you the angles, that it is a mild case. So for if it is a mild case, you can just do a simple distal chevron osteotomy plus minus soft tissue release in case if it needs, and you will be able to achieve good correction in a mild case. But if it is a moderate case, that means your hallux valgus angle is around 37 and intermetatarsal around 17. So distal chevron osteotomy will not work. So plus this joint is incongruent. If I go back, you see the joint over here was congruent. And so you don't have to worry that much in that case. But in this case, you have to bring the joint back and make it congruent, and plus the uncovering of sesamoid you can see. So that also has to be covered. So in this case, you will have to do a soft tissue release, plus you have to do an osteotomy. Maybe you can do for shaft, or maybe you can do proximal osteotomy. If it all depends on where you have been trained. If you ask me, I am very happy doing a scarf osteotomy for my moderate or severe cases. That's what I have been trained with, and I'm happy with the way I've been doing and getting my results. So I will do it. Plus, Aiken procedure, in case if there is a after that you see that there is a little bit of deformity which has not been corrected, plus the pronation has not been corrected, so you can add Aiken's procedure along with it, and that usually does the trick. So that's case of a scarf osteotomy. And now coming to the severe deformity. So that is a severe deformity. The angles of hallux valgus angle is more than 40. And now this is the case where you have to decide, because you have got a deformity which is more than 40 degrees. And so if you want to do a scarf with Aiken, yes, go ahead, you can do it. But you have to also start thinking in terms of whether maybe doing a fusion, or whether maybe doing something more proximal would help. So whichever way you have to decide, you decide and discuss it with your patient, or maybe you can explain to your examiner also that you can do something which is more proximal, or maybe do a procedure over here because for like a Lapidus procedure. Or you can do an MTP arthrodesis also. Now, if you have got a hypermobility at the TMT joint, so then definitely you have to work on the TMT joint, and the best procedure would be to do a Lapidus procedure, fusion here. And if you do a fusion here, you will be able to correct the intermetatarsal angle, and the correction, you can achieve a very nice correction over here. And if it is an arthritic joint, then you do an arthrodesis. Yes, Keller's procedure is also there, where you resect the proximal third of the proximal part of the proximal phalanx, but that should be condemned. It's not a good procedure. Patient does not like it, and they get a cock-up deformity after that. But in some situations, you may have to do it. And so if we come to the discussion part of the surgery for hallux valgus, it mainly has got two components. You have to look at the bony as well as the soft tissue balancing.
Rajat, please wrap up.
Yeah, this is the last slide. So so both the deformities has to be addressed, otherwise your surgery is going to fail. Now, and the other thing is, just correcting the hallux valgus angle is not going to solve the purpose. You have to correct the intermetatarsal. So both the angles have to be corrected. If you are doing any bony procedure, you will end up with shortening of the first metatarsal. So the shortening of first metatarsal will lead to transverse metatarsalgia on the second and third. So you don't want to do that. So you would like to maintain the length of first metatarsal, so maintain as much as possible. For that, I think scarf osteotomy is good. It helps you to do that. And if you have managed to do everything right, you should be able to relieve the lesser rate transverse metatarsalgia after this. I think we will stop here. I would not like to go into the details of the surgery.